Imagine telling a master surgeon, someone whose, entire life and training is dedicated to physically fixing damage with their hands, that the absolute best thing they can do for a devastating internal wound is absolutely nothing.
Right, just to literally walk away and let it sit. It fundamentally challenges the core dogma of the entire profession.
Exactly. Because the historical model has always been, see disease, remove disease. If there's a defect, you close it. If there's a tumor, you cut it out.
Yeah, but the reality of modern clinical management is, it's far more subversive than that. And honestly, it often demands way more discipline than just picking up a scalpel.
Which is exactly why today we are doing a special Surgical Thinking Academy deep dive. We've got this really dense stack of clinical management notes, and we are decoding the surgical principles of, honestly, one of the most anatomically complex and high-stakes regions of the human body, which is the rectum.
It really is a high-stakes area.
It is. And our mission today for you, the listener, isn't just to list a bunch of medical facts or read from a textbook. We really want to extract the underlying strategic logic from these sources to understand how modern medicine actually approaches these severe structural and oncological crises in this space.
Right, because surgical thinking has evolved into this highly nuanced game of like strategy and timing and biological synergy, really.
Yeah, so to understand that strategy, we have to start with the map the surgeon is navigating, right? Because the anatomy of this 12 to 15 centimeter organ pretty much dictates every single clinical decision.
It does. It's a relatively short span, but it's divided into three distinct clinical levels. You measure from the anal verge, so you've got the 0 to 6 centimeter lower section, the 6 to 12 centimeter midsection, and then the 12 to 15 centimeter upper section.
Right, and it isn't just, suspended in a void either.
Yeah.
The notes really emphasize these critical fascial planes that act as structural guardrails.
Yes, the fascial boundaries are crucial.
You have Dennevilliers fascia in the anterior, which separates the rectum from the urogenital structures, and then Waldeyer's fascia in the posterior, tethering it to the sacrum.
Exactly. And those fibrous boundaries define the physical surgical approach, but arguably the most striking geographical feature detailed in these notes is the pectinate line.
Oh, the pectinate line. I was conceptualizing this as I was reading, like a continental divide on a mountain range.
That's a really good way to think about it.
Right, like a drop of water falls on one side of the ridge and flows to the Atlantic, and a drop falls literally a millimeter away on the other side and flows to the Pacific. Based on the sources, the pectinate line does exactly that, but for the body's lymphatic drainage.
Yeah. Building on that continental divide analogy, the pectinate line represents this absolute embryological border checkpoint. Above that line, the lymphatic fluid, which is, the primary highway system for cancer, spread, drains upward.
It goes up toward the inferior mesenteric artery, right?
Exactly. It follows the IMA and the inferior mesenteric vein directly into the mesenteric lymph nodes.
But then, dropping below that line causes the flow to completely reverse.
Completely reverse. It drains downward and outward. It goes into the pudendal and iliac nodes, and it can even extend all the way out to the superficial inguinal nodes.
Wow. So if a tumor is kind of straddling this boundary, or maybe sits just a few millimeters below it, the clinical staging and the whole operative field have to radically shift.
They have to, yeah. You have to account for an entirely different systemic pathway. And this topographical reality is exactly why the sources place so much emphasis on the, what they call the holy plane of the mesorectum.
The holy plane, that was pioneered by Richard Heald, right?
Right, Richard Heald. The mesorectum contains all those upward draining lymph nodes within a very distinct fascial envelope. So Heald's total mesorectal excision, or TME, it basically revolutionized rectal cancer surgery.
It provided a literal map, right?
Exactly, a map to dissect sharply along that avascular plane. You can remove the entire intact lymphatic package without reaching the tumor capsule or the mesorectal fascia, which, massively reduces local recurrence rates.
Okay, so we see how delicate and highly specific this intact geography is. But that completely changes when the anatomy is just obliterated by trauma.
Oh, absolutely. When you're dealing with high-velocity gunshot wounds or impalements or severe pelvic fractures, it's a mess.
Yeah, and the sources outline the classical 4Ds of trauma management here: divert, drain, direct repair, and distal washout.
Right, the 4Ds.
And diverting the fecal stream with a proximal stoma, and draining the presacral space to manage contamination, that makes total logical sense. But the clinical consensus shows this massive modern shift regarding extraperitoneal trauma specifically.
Yeah, this is where it gets really counterintuitive.
Right, because the notes state that routine direct repair is no longer required if the extraperitoneal injury is inaccessible, which I have to push back on this, because leaving an actively leaking hole alone inside the body seems completely reckless.
It sounds reckless, right? And I mean, it raises intense debate even among veteran trauma surgeons. But you really have to look at the geometry of the extraperitoneal space.
Okay, lay that out for me.
So it is buried deep within the narrow, bony funnel of the true pelvis. If a surgeon attempts to force a primary repair on a defect they can barely even see, they are essentially operating blindly in a pool of blood.
Oh, wow.
And the mechanism of injury, like a bullet or a bone fragment, has likely already disrupted the local venous plexuses.
So digging around in that really tight space risks uncontrolled hemorrhage.
Massive hemorrhage, and also severe collateral damage to the autonomic nerves that run right along the pelvic sidewalls. That collateral damage is often far more lethal than the primary hole itself.
That makes a lot of sense.
Yeah.
So doing less is actually safer.
Much safer. Modern outcome data proved that if you just do the first 2 Ds, so you divert the flow so no new contamination enters, and you drain the presacral space so the exudate can escape, the body's inflammatory response is actually remarkably efficient at sealing that extraperitoneal hole on its own.
Just because it's a contained space beneath the peritoneal reflection?
Exactly. The risk of systemic peritonitis is vastly lower there. So doing less, or doing nothing at all to the hole itself, literally yields a higher survival rate than some heroic forced repair.
Wow. Okay, so we see this less is more approach in trauma, but the requirement for restraint becomes even more extreme when the damage isn't from, like, external kinetic forces, but from internal complications.
Right, specifically rectovaginal fistulas.
Yeah. The sources use the Ocrit mnemonic for the causes here. So that's obstetric, Crohn's, radiation, iatrogenic, and trauma,
Right, and obstetric trauma remains the most prevalent cause in the developing world.
which usually results from a prolonged second stage of labor, right?
Yeah.
Or severe fourth-degree tears where the ischemic pressure of the fetal head just causes tissue necrosis.
Exactly. And the gold standard for a fresh obstetric fistula is, and this is tough for surgeons, a strict 3-month waiting period.
A 3-month wait. I read this and I immediately thought about the mechanical properties of the tissue. I mean,
Yeah.
attempting to suture a fresh fistula defect seems functionally identical to trying to sew wet tissue paper.
That's a perfect analogy. The sutures are just going to cheese wire right through the tissue.
Right. So why 3 months specifically?
Well, the cellular biology of the injury site makes immediate repair impossible. During that acute phase, the local tissue is entirely governed by an inflammatory cascade. It's edematous, it's friable, and it is just packed with neutrophils.
So it's just angry, swollen tissue.
Very angry. You have to wait 3 months for that acute exudate to clear. The wait-up period allows fibroblasts to infiltrate the area, lay down a provisional matrix, and eventually replace it with cross-linked collagen.
Ah, so it actually gets strong again.
Exactly. Only then does the tissue possess the tensile strength necessary to actually hold a surgical suture.
Which gives the surgeon a few options if the fistula doesn't just close spontaneously during that period. The notes highlight the advancement flap as kind of the workhorse for local repair.
Yes, the advancement flap is very common.
But for complex or recurrent defects, they transition to interposition flaps, like the gracilis muscle transposition or the Martius flap, which uses the bulbocavernosus fat pad.
Right, and the underlying logic of those complex flaps relies heavily on angiogenesis.
Building new blood vessels.
Exactly. When local tissue is heavily scarred or compromised, simply pulling it together creates tension and ischemia, lack of blood flow. By swinging in the gracilis muscle or a Martius flap, the surgeon is physically importing a robust, uncompromised blood supply right into the defect.
That's amazing. They're bringing the healing mechanism with them.
Exactly. That fresh vascular network is what guarantees the healing of the fistula tract.
So that biological prerequisite for, quiescence, for things to calm down, that applies heavily to the C and Ocrit as well, right? Crohn's disease.
Oh, absolutely. With Crohn's, the transmural inflammation turns the local tissue into an incredibly hostile environment.
Right. The protocol mandates the aggressive use of biologic therapies to achieve deep clinical remission first, because any surgical intervention during an active Crohn's flare is pretty much guaranteed to fail.
Yeah, the surgeon has to just step back. Let the targeted biologics suppress the immune system's attack on the mucosa. Only when the tissue is totally calm can an advancement flap even be considered.
Wow. Okay, so just as Crohn's creates this inflammatory environment that prevents surgery, we see similar hostile tissue conditions caused by microscopic invaders. and ironically by curative therapies as well.
Right, let's look at infectious proctitis first. The notes use the GLCH pneumonic gonorrhea, LGV, chlamydia, and herpes.
And LGV specifically is flagged for driving severe strictures and granulomatous disease, right?
Yeah, it can be very destructive locally.
But the pathology that requires the most fascinating intervention in the notes, I thought, was radiation proctitis.
Yeah, radiation therapy for pelvic malignancies, whether it's prostate, cervical, or rectal cancer, is a total double-edged sword.
Because it eradicates the tumor, but the ionizing radiation triggers what the notes call obliterative endarteritis in the healthy surrounding tissue.
Right. It permanently scars and narrows the microscopic capillaries feeding the rectal mucosa, which creates a chronic hypoxic environment, a severe lack of oxygen.
And the clinical manifestation of this involves telangiectasia, right? These fragile, widened vascular webs that lead to ulcerations and severe refractory bleeding that can happen like years after the radiation exposure.
Years later, yeah.
Huh.
And because the microblood supply is permanently altered, cutting into this tissue is a massive liability. The morbidity of traditional resection in irradiated pelvic tissue is notoriously high.
Because it just won't heal.
Exactly. The anastomosis simply will not heal without adequate blood perfusion. So the toolkit has to shift to highly targeted endoscopic and chemical interventions.
Like argon plasma coagulation, or APC. The notes say this utilizes high-frequency thermal energy delivered via ionized argon gas to basically vaporize and coagulate the vessels without direct tissue contact.
Right, which minimizes the depth of the injury while stopping the bleeding.
And if the bleeding still won't stop, the notes indicate the use of a 4% formalin installation to chemically sclerose the bleeding mucosa. But, and this is where it gets crazy, the most sci-fi intervention listed for chronic, stubborn radiation proctitis is hyperbaric oxygen therapy.
Yeah, HBO therapy.
I mean,
Yeah.
I usually associate hyperbaric oxygen with deep-sea scuba divers suffering from the bends. Reversing radiation damage inside the pelvis using a pressurized oxygen chamber sounds like physiological magic.
It sounds like magic, but it relies entirely on Henry's law of gas solubility.
Okay, take me back to chemistry class.
So as we established, the irradiated tissue is hypoxic because the capillaries are obliterated. Under normal atmospheric pressure, oxygen delivery is limited by the oxygen-carrying capacity of hemoglobin in your red blood cells.
Right.
But when you place a patient in a hyperbaric chamber at 2 to 3 times normal atmospheric pressure and they're breathing 100% oxygen, you physically force the oxygen to dissolve directly into the blood plasma itself.
Oh, wow. So you're completely bypassing the damaged red blood cell delivery mechanism.
Exactly. You are saturating the plasma to the point where the oxygen diffusion distance into the tissue increases exponentially. And this massive influx of oxygen into the hypoxic tissue upregulates vascular endothelial growth factor, or VEGF.
So the body recognizes all this new oxygen availability and initiates angiogenesis.
Yes. It physically sprouts brand new capillary networks. Over the course of maybe 30 or 40 sessions in the chamber, the body literally rebuilds the vascular infrastructure that the radiation destroyed, which allows the ulcerations to heal from the inside out.
That is just incredible. And this profound reliance on the body's internal mechanisms, guided by technology, kind of brings us to the ultimate test of modern surgical thinking, which is oncology and functional failure.
The shifts in clinical management here really represent the absolute pinnacle of the field. Even just looking briefly at functional failure, like severe fecal incontinence when conservative measures fail, the gold standard now is sacral nerve stimulation.
S&M,
Yeah.
which is essentially implanting a pacemaker for the pelvic floor, right?
Right. It relies on continuous neuromodulation of the S3 nerve root to optimize the tone and function of the anal sphincter complex.
So it completely bypasses the need to mechanically reconstruct the muscle.
Exactly. It proves that structural integrity is only half the equation. The electrical and neurological balance is equally critical. But, I mean, the true revolution detailed in these sources lies in the staging and treatment of rectal cancer.
Yes, the oncology section, the entire oncological pathway, is dictated by high-resolution MRI. It's the absolute gold standard for local staging. And the radiologist is interrogating the scan for two critical parameters, right? The circumferential resection margin, or CRM, and the presence of extramural vascular invasion, EMVI.
Right, because the distance between the advancing edge of the tumor and the mesorectal fascia completely determines the risk of local recurrence.
So if the MRI reveals a very early, low-risk T1 lesion, surgeons can deploy transanal endoscopic microsurgery.
TEM, yeah. TEM allows for a full-thickness local excision through the natural orifice using specialized optics. You completely avoid radical abdominal surgery.
But when dealing with locally advanced disease like T3 or T4 tumors, or node-positive staging where that CRM is threatened, we enter the era of TNT, total neoadjuvant therapy.
This is a huge shift. Historically, the reflex was to operate immediately, get the tumor out, but TNT completely flips the protocol. You administer the entire course of systemic chemotherapy and pelvic radiation up front before any surgical intervention is even scheduled.
What's the logic behind doing all that heavy therapy up front?
It serves a dual purpose.
Yeah.
First, patient compliance and tolerance for systemic chemo is exponentially higher before they undergo the trauma of major pelvic surgery.
That makes total sense. They're stronger.
Right. And second, and arguably more importantly, it aggressively downstages the primary tumor. It shrinks it away from the mesorectal fascia to ensure a clear CRM while simultaneously neutralizing any microscopic systemic metastases from day one.
Wow. And this leads to what is arguably the most controversial, yet now completely vindicated, evolution in the notes, the Haber-Gamma watch and wait protocol.
Yes, Angelita Haber-Gamma.
She observed that following this intense upfront chemoradiation, a subset of patients exhibited a complete clinical response, right? The tumor just vanished entirely from the endoscopy and the MRI.
It just melted away.
And her proposition was radical at the time. Instead of performing a morbid TME surgery just to examine empty tissue under a microscope, you omit the surgery entirely. You put the patient into a strict surveillance program. You watch and you wait.
I mean, think about it. It requires an immense leap of faith, backed by rigorous data, of course. Surgeons had to accept that their operation wasn't always the curative step,
Yeah.
and that conceptual leap really sets the stage for the final and, frankly, most staggering clinical trial documented in these sources, the one involving the immunotherapy drug dostarlimab.
Oh man, this trial. It targeted a highly specific subset of patients with locally advanced rectal cancer characterized by MSIH or mismatch repair deficiency.
Right. Tumors with mismatch repair deficiency basically lack the cellular machinery to fix DNA replication errors. This results in a massive accumulation of mutations, which is known as microsatellite instability.
And because they're so highly mutated, these tumors generate a huge number of neoantigens.
Exactly, making them incredibly conspicuous to the body's immune system. The immune system should easily see them and destroy them.
But the tumor utilizes a biological cloaking mechanism to survive. It exploits the PD-1, PD-L1 immune checkpoint pathway, effectively sending an off signal to the CD8 positive T cells that would normally attack and destroy it.
That's where dostarlimab comes in. It's a monoclonal antibody designed as a PD-1 checkpoint inhibitor. It blocks that off signals.
So it strips away the tumor's cloaking mechanism.
Completely, unleashing the patient's own native T cells to recognize and annihilate the highly mutated cancer cells.
And the results of this dostarlimab trial, they defy traditional oncological expectations. It yielded a 100% complete clinical response rate.
100%.
Every single patient in the cohort saw their tumor entirely eradicated. They required zero chemotherapy, zero radiation, and zero surgical intervention. Just the targeted biological uncloaking of their own immune system.
It is an absolute existential shift for the surgical profession. To look at a clear MRI where a threatening tumor used to sit, and to realize that the highest standard of care was achieved without making a single incision.
It's mind-blowing.
It proves that the ultimate objective isn't executing the perfect operation, The objective is securing the perfect outcome, even if it renders the surgeon temporarily obsolete.
Wow. And as we bring this Surgical Thinking Academy deep dive to a close, the trajectory of this whole discussion is so clear. We started with the strict embryological borders of the pectinate line.
Right.
We explored the physics of pelvic trauma and why surgeons now choose to divert and drain extraperitoneal injuries rather than forcing a repair. We examined the cellular biology of fistulas that demands a 3-month waiting period and the hyperbaric physics used to generate new blood vessels in irradiated tissue.
And we ended with targeted immunotherapies yielding unprecedented 100% complete response rates.
Exactly. It really is a masterclass in the maturation of a medical discipline. The arc bends definitively from aggressive mechanical intervention toward targeted precision and ultimately to biological synergy.
I couldn't agree more.
Which brings us right back to our opening paradox. We used to view surgical diagnosis and treatment like mechanical engineering. Find the broken part, cut it out. But given the overwhelming success of total neoadjuvant therapy, the watch and wait protocol, and targeted checkpoint inhibitors like dostarlimab, it leaves you with a thought to really chew on. Will the master surgeon of the next century be defined not by the masterful strokes of their scalpel, but by their profound mastery of knowing exactly how to avoid cutting entirely?
Looking at the trajectory of the data, the scalpel is rapidly becoming the tool of last resort, not the first line of defense.
Incredible. Well, that is all for our deep dives into the evolving mindset of the modern clinical surgeon. Keep thinking, keep questioning, and we'll catch you next time.